Hello and welcome. I am Christina Ewig, Professor of Public Affairs here at the Humphrey School and also Director of the Center on Women, Gender, and Public Policy. We are thrilled that you have joined us today for the launch of the latest research report published by the Center on Women, Gender, and Public Policy titled Essential and Exiting COVID-19's Impact on Low-Wage Healthcare Workers. Before we launch into the report findings and discussion by our distinguished guests, I want to begin by acknowledging that we live, learn, and work each day on traditional, ancestral, and contemporary land of Indigenous peoples. The University of Minnesota Twin Cities is located on Dakota land, ceded in the treaties of 1837 and 1851. And this institution would not be here today if not for the vast land resources taken during European settlement. This land acknowledgement, which we do at the beginning of all of our events, is one way to educate our campus and community about this land, our relationships with it, and each other. Of course, it's only a start of the decolonization process. I'd also like to express my gratitude to the Time's Up Foundation. The report that we're releasing today is a result of a competitive research grant that the center and its research team successfully won from the Time's Up Measure Up initiative to study the impact of COVID-19 and the crisis that ensued on gender and racial inequalities. The Center on Women, Gender, and Public Policy at the Humphrey School of Public Affairs is dedicated to illuminating gender-based disparities and their intersections with other forms of inequality through research and teaching and public engagement in events like these. This report that we are presenting today is co-authored by Janette Dill, Jane Van Hoevelen, and Tom Van Hoevelen. It's one example of the kind of work we do, research into pressing public policy concerns with an eye to the impacts on those that are most vulnerable. There is no question that at the height of COVID-19, we faced an unprecedented crisis in Minnesota and around the country. Nursing homes in particular went into lockdown. Hospitals were overwhelmed, while others may have been able to work from home. Healthcare workers worked around the clock, interacting every day with patients and peers in work contexts where the virus was most likely to spread. So this report that we are launching today, Essential and Exiting, uses quantitative analysis of employment trends coupled with interviews with direct care workers in Minnesota to understand how the COVID-19 crisis shaped direct care workers' decisions to stay or leave the low-wage care workforce. As we'll learn soon, many of them have decided to leave. And we're feeling that those ramifications on the workforce here. In fact, in 2020, the Minnesota nursing homes reported the largest staffing shortages of any state, more than any other state in the United States. This, of course, impacts the quality of life of residents in nursing homes and causes great concern for family members for the safety and well-being of their loved ones. Today, we have with us the lead author of this report, Dr. Janette Dill, who will provide us with an overview of the findings. Dr. Dill is Associate Professor in the Division of Health Policy and Management of the School of Public Health here at the University of Minnesota. Trained as a sociologist, her research focuses on the healthcare workforce with a particular focus on low-wage healthcare workers and racial and gender disparities among these workers. Her publications have appeared in a range of highly regarded sociology and public health journals. We will then turn to commentary and questions from three distinguished guests. Two are Minnesota State Senators, Senator John Hoffman and Senator Jim Abeler, and also President of SEIU Healthcare Minnesota and Iowa, Jamie Gulley. Senator Jim Abeler is a member of the Republican Party and has represented Legislative District 35 since 2016. Before that, he served in the Minnesota House. A leader on healthcare policy, Senator Abeler serves on the Aging and Long-Term Policy Committee and the Committee on Human Services Reform and Finance Policy. In addition, he serves on the Health and Human Services Licensing Policy Committee. Senator Hoffman is a member of the DFL and has represented Senate District 36 since 2012. He is another advocate for healthcare issues and serves on the Senate's Aging and Long-Term Care Policy Committee and the Committee on Human Services Reform and Finance Policy. And Mr. Gulley is president, as I mentioned, of the Service Employees International Union Healthcare of Minnesota and Iowa. Mr. Gulley joined SEIU as an organizer in 2002 and was elected president in 2012. He has led some of the most important victories in SEIU Healthcare Minnesota, including organizing campaigns that brought in more than 30,000 new hospital, nursing home, and home care workers, tripling the size of the union, and leading negotiations for a $15 minimum wage in all Twin Cities hospitals and clinics. He's now engaged in a negotiation to raise that wage even more. We look forward to Mr. Gulley's insights as a union representative of direct care workers in Minnesota's labor force. A few housekeeping notes to audience members. The chat is disabled, but please use the Q&A function to ask your questions of the speakers. Live transcription is also available. I will be checking throughout our conversation on the Q&A to weave your questions into our conversation and present them to our guests. And now we will move on to our presentations. I'd like to start out with the lead author of our study, Dr. Janette Dill. Dr. Dill, can you start us out with a brief overview of the report? What were the questions that you and your team sought to answer, and what did you find?
Great. Well, I want to thank you for the invitation to be here and for hosting this event. It's great to be here and to talk about this report today. And I also want to thank my co-investigators, Tom and Jane Van Hoevelen, who were incredibly instrumental in the data collection that went into this project and to this report. So the goal of this report was to think about the employment trajectories and the employment experiences of direct care workers during the COVID-19 pandemic. So who are direct care workers? Well, they're largely women, mostly women, and disproportionately women of color who provide hands-on care for older adults and for disabled people, providing critical services in our society. And they go by many job titles, but I like to give some examples just so people have some specific names. But these include people like nursing assistants, home health aides, home care workers, personal care aides, and it's an enormous group of women, especially for women without a college degree. The U.S. healthcare sector is the largest employer in the U.S. economy. And for this particular group of women, for women without a college degree, these direct care jobs are a huge part of our economy. So 4.6 million women in the U.S. are employed in direct care jobs. All right. So in this project, like I said, we really wanted to understand what employment was like for these women. So we used two different, it's not only women, it's just mostly women. It's about, this workforce is about 85 to 90% women. We really wanted to understand what their experiences were like during the pandemic and how that shaped their employment. So we used two different sources. First, we used the Current Population Survey, which is the largest employment survey in the United States. It's collected by the U.S. Census Bureau. It's the way we calculate our employment statistics in the U.S. It's publicly available. So we used that, and I'll explain the data that we use for that in a second. And then we also wanted to talk to workers. So we interviewed 26 direct care workers here in Minnesota, mainly home care workers, about their experiences during the COVID-19 pandemic. And what we found using the Current Population Survey was that about a little over 6%, 6 to 7% of direct care workers were exiting the labor market during the height of the pandemic in 2001, and that dropped just a little bit in 2022. So these were workers who were leaving the labor market altogether and dropping out, which was significantly elevated over levels prior to the pandemic. And this is particularly concerning in long-term care. Other sectors of the healthcare sector recovered much more quickly, but the rate of workers leaving the labor market has remained really high in long-term care. We also found that over 40% of workers switched occupations during the survey period that we were looking at. So they left direct care and switched to a non-direct care occupation during the survey period, which was about 18 months. So almost half of workers were leaving direct care work during that time period. In our qualitative interviews, when we talked with workers, what we found was that workers had a really wide range of experiences during the COVID-19 pandemic. Some of them found it to be incredibly meaningful work during that time. Some of them found it to be very scary, others did not. We heard all different kinds of experiences. There was not a lot of cohesion around workers' experiences during the acute parts of the pandemic. But what we did hear again and again from workers was that after as we came out of the pandemic and the economy recovered, the workforce shortages became so acute that their work became so difficult. So for workers who did not leave, the ones who stayed, they were faced with incredibly heavy workloads because of the shortages that were being experienced in long-term care settings. So while the pandemic was difficult in its own way, most of our respondents were saying that the work actually became much more difficult as we recovered from the pandemic because of worker shortages. And I'm going to stop there, and we can talk more about our findings if we want, and we'll get into the policy implications.
That's great. Thank you, Dr. Dill. Tell us a little bit more about the demographics of this workforce. You said it's 80 to 90% women, but it's also disproportionately women of color, right? Why is that the case?
Well, it depends on, in Minnesota, I think it's about 30 to 40% women of color. It really depends where you are geographically. But we always see a higher concentration of women of color and immigrant women in these jobs. And it really reflects differential opportunity in the United States. And I would say the legacy of slavery in the US. Among Black women, almost 25% of Black women are employed in the healthcare sector. So almost a quarter of Black women work in the healthcare sector. And most of them are concentrated in these aid and assistant jobs. We have a history of depending on Black women in particular and other women of color, and including immigrant women, to provide that kind of domestic care and domestic service. That's part of our historical legacy in the United States. And while white women have had the advantage of getting additional education and going into more professionalized care work occupations like nursing and social work, women of color have had less access to those kind of educational opportunities, and so are more confined to these low-wage care work occupations. And so we see these disproportionate representation there. Thanks.
I'm going to turn to Jamie Gulley. As a representative of these workers and one of the primary unions that represents them, what are some of the things that you heard from your union members about the impact of COVID-19 on how daily work was? Certainly the qualitative evidence in this report shows a lot of stress, a lot of anxiety by these workers. What were some of the things that you heard?
Thank you, and appreciate the opportunity to join the panel discussion. Our union is by far the largest union of the workers in the focus of the report. We represent 29,000 home care workers in the state Medicaid programs and the PCA choice and waiver programs. We also represent about 32% of the nursing home workers in the state of Minnesota. So thousands of the individuals who are the focus of this report, and just really appreciate the spotlight being shined on individuals who we consider heroes of care all the time, not just during a pandemic. And I just want to appreciate Senator Hoffman and Senator Abeler as well for joining this discussion. They both have an incredibly important role in state policymaking. So we're really excited to partner with you on how to improve the programs. The COVID-19 experience for both home care workers, direct support workers, and nursing home workers, and others who are the focus of this report, was, I think, a little bit of a unique experience. So in the 2020 timeframe, spring of 2020, until the vaccines became distributed to direct support workers in December and January later that year, it was an incredibly scary time. There was no level of preparedness by the state or the industry for the needs for PPE and other equipment. We had members in nursing homes that were working in raincoats due to just lack of available PPE. And the workers experienced a lot of loss in the early months of the pandemic, where 15% of the individuals were hospitalized who were getting COVID before the vaccines. And it's, you look back on it and it feels like a long time ago, but it really wasn't that long ago. And I would say that there is both the emotional, the physical hardship of working short, of trying to care for people in very difficult situations. There's also a lot of emotional aspects to this, where a lot of loss, a lot of people that we cared for passed away during this time period. And unfortunately for home care workers and nursing home workers, many of them ended up exiting the workforce because they got laid off, essentially. So the people they were caring for passed away. And there was not a robust system for home care workers to find new clients, or for nursing home workers to transition to another place. And so there were definitely individuals in our experience who exited the workforce for other opportunities because they needed to care for family members themselves and for reasons of that sort. But here today, coming out of the pandemic, we are still in a huge workforce shortage among these workers. So fully 52,000 healthcare vacancies today, right now today, in the state of Minnesota, with the majority of those being 15,000 just in the home care universe, tens of thousands in nursing homes and other places. So there is as much overtime as you want to have as a nursing home worker. So in some respects, they're making as much money as they ever had as an individual because of the overtime, but there is no time for break or for the emotional reflection and just the dealing with the loss. There is just a lot of lack of support for the workers who have gone through so much to help our seniors, people with disabilities, those who need care around the clock. There's just still a lot of gaps. So I'll pass here back to Christina, but I would just say that there isn't one story here. There's a lot of different stories, but thank goodness for the direct support workers and caregivers who did stick with it and who are continuing to labor every day. And we just owe them so much gratitude from the state of Minnesota, but also, as the report identifies, some meaningful policy changes in compensation and benefits moving forward in order to make sure that we keep the folks who are there and bring in new individuals into this workforce.
Thank you, Mr. Gulley. I want to turn to Senator Abeler. As a leader of the Aging and Long-Term Policy Committee in the Senate, worked on this issue. And I know this is something that the legislature did try to address to some extent in the last legislative session. What can you say to us in terms of, from your perspective, what are you hearing from constituents, whether they're workers, whether they're families with relatives in long-term care, about the situation and the impact of the labor shortage on care?
Oh, sure. It's well, thanks for having me. I appreciate all the people who tuned in here and those that are going to watch later. It is a big deal. It's gone from a kind of a challenge to a problem to a big problem to a crisis to I don't know what the next level is. But the system's on the verge of collapse. And some of the solutions that are being suggested by the report make a lot of sense. Some are doable. Some are like, well, how do we really make this work? Moving money around. But at the end of the day, people need to be able to make a living doing the work. And so the system has gone from a bunch of $12 workers overnight to a $5 raise. Perhaps some of them are, and some are getting 17, 18 bucks. Many without benefits and many, and hopefully with some upward chance to be upwardly mobile and having a career path which is what we've been trying to work on all along to help them stay. And so, but it's a real problem. And so it takes money, takes just raw money. The budget forecast came out today. But this is one of the most complex areas of policy, and it's just kind of a little arcane. Nobody understands the long-term care side. You understand, public safety, you understand education. The governor has called for spending there. I don't know where his call has been to shore up this critically essential, important area of service to Minnesotans, particularly those of, the clients are probably disparate in terms of, more than, more BIPOC and more low income and all of that. The workers certainly are. And so how do you call attention to this area that is actually being heroic and amazing and caring for the people? And maybe you'll ask me later, but I want to make sure that I mention part of that is you help draw people in by helping them enjoy the value of their profession. But you got to pay them. And the people that are working there want to stay, but they simply can't afford it. And so part of the call to action is you better get a hold of your new legislators and point out that this is just as important as any other area, perhaps even more. And we've been working on that. Senator Hoffman and I have been having hearing after hearing, trying to beat the drum about that. So.
Thank you, Senator Abeler. Maybe I'll give Senator Hoffman a chance to jump in here on your perspective. What points can we make to the new legislators that have come in and to the governor in terms of the contours of this problem and why it needs to be addressed before we turn to how we think it should be addressed?
68 new legislators out of 201 legislators, right? I got that number from Jim Abeler earlier today, just so I want to give credit to where it needs to go. But it's the act of this is critically essential. I don't think everybody along the spectrum of government understands that statement, right? And it's finally, Dr. Dill, you finally put in this, 4-page report stuff that Jim Abeler and John Hoffman have been talking about for years. And this goes back, you got Rick Varco, you got Rebecca Covington online, listening to this. And I can go back to 2013, 2014. We kept saying the silver tsunami's coming, silver tsunami. Nobody was listening, right? 850,000 kids in K-12 education has been stable for 1 million years. Well, now you're starting to see a dip in that. But yet at the same time, 65 and older goes from that to the switch. Now we're at 1.1 or 1.3 million. Just the Medicaid obligation goes from $1 billion to $3 billion. And if you're sitting there going, okay, I don't think everybody understands that impact. This report not only gets you to understanding that impact, but it also gets down to the heart of the matter, which is what are the demographics of those caregiving professions, right? And now what are we going to do about it? One of the biggest impacts that I saw, McDonald's in Burnsville. If anybody lives in Burnsville, 2 years ago, they had a sign now hiring $21 an hour. And our reimbursement rates, thank you, Dr. Dill, $14.72 an hour, right? And you sit there and we're debating, do we do a unit-based or do we do a not a unit-based, half day, all day? It's garbage. What's really important is the fact the people that need the services that we provide, they're dying. They're filling up our hospitals. There's a dude who lost his limbs because of the fact he couldn't get home health care. That's real people. Those real people stories need to be in front of not only the new legislators, but everybody across. So we're having an intersectional conversation about disability along every spectrum within government. So I hope I'm making sense, because it really drives me bananas when people get siloed. We're Minnesota, we're still talking silos. We silo this, silo that. Well, what about this jurisdiction? What about that jurisdiction? Who gives a rat's, right? The jurisdiction here for us is caregiving is a system. Like Jim says, the infrastructure is falling apart. 53,000 job vacancies, and nobody is having a serious conversation about paying people what they need to be paid and give them value for doing what they do. The folks that are sticking on, They actually are doing it because they love working with people. Now let's pay them what they need to be paid. So
that really brings us to some of the core findings that need to be addressed by policy from this report. One is the low wages, right, that Dr. Dill outlined and Senator Hoffman just reiterated. Low wages for work that is extremely hard work. We have higher injury rates among these healthcare workers than we do among firefighters, for example, right? So hard work that has its risks. Clearly, the risk of COVID-19 add on to the injury rates that I'm talking about are more like lifting patients, for example, right? So here, increased risks, moreover, with the COVID-19 at low wages. We have Dr. Dill laying out the high stress levels of the shortages themselves, right? You may have the opportunity of working overtime, as Mr. Gulley has laid out, but that's at the expense of one's own health in terms of being able to have take care of one's own well-being and also bring in that paycheck. And we also heard that emotional piece. So Mr. Gulley mentioning that those loss of the clients themselves, when one's life's work is taking care of others, to lose those people as part of your work and part of your job is a trauma in and of itself. There's more of the qualitative work in the report itself that details workers talking about that speeding up due to the shortages meant the loss of the time that they could spend with clients. The kind of things that bring them joy in the work are missing, and also the things that those that are the patients and the family members want to have for their loved ones or for themselves, that time with those workers. So those are some of the things that the report brings out, that our conversation has brought out, but it's time to turn to what are the policy solutions to this. So it's easy to point to the wage piece, and I would like us to talk about that, but there are other pieces to the puzzle. Jamie Gulley has mentioned other kinds of benefits beyond wages, which are also important, right, for dealing with the different risks that we face as individuals in life, right? Whether it's pension insurance or care for our children. So I want to move first to the recommendations that are outlined in the report itself, but then have a more freewheeling conversation about whether there are other ways that we see to address this really critical issue that I think Senator Hoffman's absolutely right, has been overlooked, in that we don't often put our lens on the older population, right? Seniors. And we don't often put our lens on those workers that are often those that are most marginalized. They're the lowest paid, they're facing intersecting inequalities. In this case, both gender, race, along with socioeconomic status. Okay, so one of the big policy recommendations in this report is to redistribute Medicare and Medicaid funds in order to provide higher wages to direct care workers. And I'd like to turn it over to Dr. Dill to explain to us what this would mean. What is this proposal for those who may not understand, especially how these programs work?
Yeah, and I would say this is a very high level policy recommendation. I think when we look at the United States, right, we have a very high degree of inequality within the US, sort of a very high range between the top and the bottom. And the same is true within our healthcare system in terms of the degree of inequality in terms of who makes the highest wages and who makes the lowest wages. And, and Medicaid is one of the factors here, also Medicare and private insurance. But when we look at the difference between, what a physician makes and what a direct care worker makes, the level of inequality is very high. And that's very different than many other countries where the range between what a physician makes and what other healthcare workers makes is much more constrained and much lower, right? So this is a very high level sort of recommendation, but if we think about raising wages for our direct care workers, right, that is an enormous burden on Medicaid. Jamie Gulley and I have talked about this. It's such an enormous workforce, right? If you raise wages for direct care workers, we're talking about millions of workers. And and that is an enormous burden on Medicaid. So I think that we have to think about the way that our funds are distributed within the healthcare system. We can't just say we need to pay more. We have to think about the way that we're distributing the money that we are already spending. And I think we can look to the way that we are spending our Medicaid and Medicare funds and think about some redistribution there. So I'll just end with that. The other angle I want to add here is that, we've had a shift in long-term care towards home and community-based care services. And that has implications for direct care workers, because when you have someone who works in a nursing home, you have a certified nursing assistant who works in a nursing home, they are going to make a little bit more money than someone who provides care for someone in their home. It's they're generally paid a little bit more, but we've had a shift away from nursing home care and towards home-based care, and so that means that sort of the average money that these direct care workers are making is sort of shifting downward a little bit, and I think we need to be thinking a little bit about the implications of that and how we're reimbursing for that type of care. So I'll stop there because I know that the other guests have things to say about this as well.
Yeah, I want to turn to Senator Abeler first and then Senator Hoffman about this idea. Obviously, these are federal programs. How much room to maneuver is there at the state level to work with these Medicare, Medicaid reimbursement rates? Or is this just a kind of policy recommendation where we should be focused on our federal delegation and making change?
I don't think the problem is a federal one. In fact, we just are in an extension of the emergency, the COVID emergency, which has given us another bump, I think 6% of extra money. We just got off a call with REM a little bit ago, another provider group, as they're trying to do the same things as many people on this call. So when you read the forecast, which came out today, there's like $17 billion or something. And a lot of it's, some of it's one time. And so we have a lot of money. And part of that, what was the number, John, 650 million or so of that surplus is actually increased match from the feds because of this COVID extension. That number does not go into a jar to be spent on wages and the likes of that. And frankly, in the niche that you're talking about today, that actually would remedy pretty much the needs for the next couple of years to get wages into where we were hoping to get them last year in the Senate bill, which was bipartisan and well received by everybody except for the administration and the House. But so that money goes to the bottom line. That money is now in the fray to be argued about. Is this education money? Is it childcare? Is it roads? Is it clean water? None of which are anything bad, but now it's competitive. And so the money's sitting right there for $600 million that came and just fell out of the sky as a special surprise in the forecast. And so if you want to try to take, I don't remember the budget, it's like $40 billion a biennium or something when you add the federal money in. It's in the range, it's a huge number in the DHS and Human Services budget. All the people on this call who've been around a while will tell you it's hard to take money from one place and put it somewhere else. Because the people that you're taking it from feel like that's not a good idea, even though if their programs are not as useful. And so if you raise anything, you have to raise that, you hold something flat and then raise something else. And then they say, well, where's our increase? And so there's a lot of competition for that. The real issue is a matter of priorities. What is the priority? And if you ask people in a vacuum, do you think that seniors and persons with disabilities and special needs and the like, and the workers who support those are a high priority? Oh, absolutely. But then you want to see where they're putting in their money, and not to be at all political, but just in terms of like, what the heck? The debate lately coming out of the governor's office has been public safety and education. Big fans of both of those. But the people on this call and in every spread around the whole state need to get this topic on the list. And then it can be competitive for the money that's out there waiting to be spent in the surplus. So I'll leave it at that. But I cannot tell, well, I guess I'm not. I just can't tell how frustrated I am working with the department and people who care. And they're calling the Senate bill would give you all a windfall. Like some person's going to go from $14 to $17. That's a windfall. You know, like what on earth? And or get them from 17 to 20, or getting them from 18 to 22 with benefits is a windfall. So that's what you're fighting. It's nothing. There's no enemies. There's just people that are kind of listening to other voices as well. So anyway,
Interesting.
what
So
do you
what
think, John?
what I hear you saying, Senator, is at this point in time, given that we, with the state projected budget forecast right now of a surplus of 17.6 billion, we would not need to do this redistribution of Medicare, Medicaid, but rather the money is sitting there to provide wage increases for the next few years. That's what I hear you saying. Senator Hoffman, do you
Yes.
want to weigh in?
Yes, I'll leave it at
Yes.
that. Yes.
Okay.
Yeah, absolutely. Thank you. Yeah, you know, it's when people personalize anything, a conversation, it becomes far-fetched from really the focus at hand. Jimmy Ramstead used to say, leave your ego in the hallway when you're talking about health and human services and education. Focus on what you're supposed to be focusing on. This was, 20 years ago. And that's relevant today, because most of the comments, it's a windfall. That's a personalized comment, right? If you really truly wanted to look at the system whole, you wouldn't be making statements like that, right? That's a statement from me to you, right? I've personalized this. And it's not about me. It's not about Jim. It's not about you. It's about the individuals we're supposed to be serving. And it just absolutely, I'm holding my tongue because there are lots of things I want to say, but I'm not going to say because this is a public forum and somebody will say, I heard you say this, Hoffman. Did you say that? Well, yeah, I probably said that. But here's what it does. It comes back to a couple of things. Centers for Medicaid Services in a Medicaid plan, right? They say to a state, and when you see one Medicaid plan in a state, guess what, folks? You see one Medicaid plan. Every state has their own way to set up their Medicaid plan. It's the leadership of the person that's developing that Medicaid plan. I'll give you an example. When we wanted to give $36 million a few years ago during the start of the pandemic, right? And I forget what we were calling that term, Jimmy. What was it? I don't know. We were trying to we got assurances from the feds that you could go ahead and take that money. You don't have to worry about the match, and you could redistribute that to those services, elderly services, day programs. It's $36 million, right? And folks kept saying, oh, no, we can't do that. We can't do it. But we knew we could. Matter of fact, we even pulled in other states. And one state, and I won't give you the state, but it's a state on the West Coast. It's the northern tier of the West Coast. If you go over there and you look at, and matter of fact, their Title V public health grant, I just was a viewer. I'm a HRSA reviewer, and I reviewed that a few weeks ago. So I won't tell you where that state is, but it's by Oregon, and it's probably the state next to that. So there you go. You can figure this one out. But their Medicaid director, our staff called and said, hey, do you need legislative authority to do this distribution of these funds? And he said, no, why would I need that? I'm the Medicaid director, right? So there's one state that does it one way, and here's our state that kept saying, oh, no, it's up to the legislature. Yet when the legislature does it, there was an impasse because there was somebody on the other side who was saying, oh, no, you can't do this. We passed that, the distribution. I can't remember what we called the term. Jim, do you remember the name of the term? But 4 times, right? That we say that, Kevin? Retainer payment. Retainer payment. Thank you. I just had my staff yell, that's retainer payment. See, he forgets more in a day than I'll ever know. 4 times we passed it, right? Unequivocally sent it over and nothing was done with it. That comes back to that first piece about, all right, if we're going to do something, we got to get everybody in the conversation. Everybody's got to be at the same table, understanding, right? And they don't personalize. This is my money, right? Can't do that, right? Now let's go back to the Medicaid question that you had, Doc. Each state has their own variance of what Medicaid looks like, right? And so what you need to do is you got to pick into somebody, I don't know, like an Alan Bergman, who nationally, I made the comment at a conference. Bergman was the guy who negotiated between Trent Lott and Ted Kennedy on Senate File 331. It was the Welfare Work Incentives Improvement Act that was done in the late 90s. And I was blown away at how Bergman was able to do this. And I introduced him to Jim Abeler, and I said, Jim, this is probably the smartest guy when it comes to Medicaid in the nation. And Bergman corrected me in this meeting, and he said, no, I'm not the smartest, but I'm in the top 3, right? But you need to get somebody like that who understands the conversation of redistributing Medicaid or Medicare spending so that it's very clear and precise about what that means, what that definition means. I think you do both. You increase the money going into that bucket, but then you look at how in the heck are we spending money in the first place, right? Because there's a lot of this, the $600 million that's being distributed, dropped to the bottom line, should never happen. You should never have that option ever happen, right? Since I'm on the topic, back when I did Part C of early intervention services, a state south of us used to give money back to the feds, right? Because they didn't spend their allocated money. That money that was geared to go toward that population of kids birth to 3, Part H became Part C, right? Early intervention services. And I said, no, you never give that money. The money was already allocated, or the money was already forecasted to be spent on that, right? In the same sense, but it had to go back. I never understood that. And to this day, I don't understand. $600 million going to the bottom line. It's going to pay for a gravel road. Sorry, if I'm going to make somebody mad about gravel roads, I don't care. But in this case, how do we then policy wise, and Jamie, maybe this is where we go with this, Jim, is to make sure that any of that money that is at the bottom line has to go back into the bucket where it came from. That would be something that would take, I don't know, an act of God in Minnesota, I suppose. But there, I give you enough to think about, huh, Christina?
Yeah, thank you, Senator Hoffman. So it sounds like we can do something about redistribution if there's the political will of Medicare and Medicaid funds to address this issue, as well as use some of this short-term surplus to raise wages. Before I go to Jamie Gulley with some questions about unions, I want to go to a question we have here in our Q&A. This is from a Masters of Public Administration student, Hannah Lixon, who is also a physician at HCMC. She says, currently our ability to provide care to patients in Minnesota is limited because of inability to discharge patients from hospitals into acute care or long-term care centers. This means that hospital beds are full, often with patients who are well enough to leave, and our emergency rooms are overflowing because there is no room in our hospitals for them to get care. It's unsafe and it's getting worse. So Hannah asks, what short to medium-term policy solutions do you see that could create access to TCUs and nursing homes to break this cycle? Do you see a role in incentivizing private insurance companies to subsidize this care so that we are able to create access again in our hospitals? So this is like moving the responsibility off the state here, but rather to insurance companies. I'll open this up to any one of you that wants to answer it. What are your thoughts about an incentive structure? Senator Abeler.
Well, sure, it's a big deal. And actually back to the marketing of how to get people's attention about this area. The average legislator, the average governor, they understand hospitals. Well, hospitals, oh, we get that. And so now they're all jammed up because of these folks. I did talk to the commissioner and Jennifer DeCabellis at Hennepin Health. It turns out a good number of these people, and there's a lot of them. I don't remember 50 or I don't know the latest count, but it's a big number taking up their beds. A lot of them don't have their fiscal stuff put together. I don't know why in a state where you have such broad allowance for Medicaid and so on, that sometimes they're not clear about what their coverages are. That's part of why they're there. But the idea that occurred to me as I was talking to the long-term care side was, what if we, and a lot of those are really complex cases. And so if we would give an incentive to the nursing homes and facilities to take these cases that are stuck there, that are more complicated, that was an idea. And then I was told about this financial status is unclear. So, and I just use that as an example to remind everybody, you can have a program, you can have a law, but then it has to be implemented. And so we passed, John and I passed laws, you help us, hey, we passed a law, and here we go, on to the next thing. And it may take 1, 2, or 3 years to actually get a program up and running. But it's a big deal. But I'm gonna come back to, we've got to get the attention of the people that are watching and caring about the money. That'd be the House leadership, and nothing against them, but they have to understand this is a priority, as well as the administration as well. I think John is gonna be able to carry the water in his caucus. The Senate already has gotten squarely behind this, and in a it's not a partisan thing at all. It's like, just fix it.
Does anybody else want to comment on this idea of incentivization of insurance companies?
I think you incentivize, like Jim says, the vendor, the person, right? I went out to Cockatoo, Minnesota. Well, if you're from there, it's Cokato, right? Cokato, Minnesota. It's the Finnish term, cockatoo. Anyway, sorry, Jim. My wife told me don't try to be funny. You're not funny. So, but they're closing down wings that they were providing services to folks that really had the higher need, and they're only bringing in people that don't have the higher need because of staffing shortages. Jamie, to your point, right? I mean, it's like staff shortages because of the pay piece, right? And then they're now dipping into whatever slim reserves they have in order to increase wages without getting reimbursement in order to take care of those folks that aren't needing the higher needs piece, right? And those higher needs piece folks, they went to the hospitals. That's why you get the report from Mercy and you get the report from Hennepin Health. You get these at up to 20% of their bed space right now are those folks that should be someplace else. That's kind of mini institutionalization. I don't know. The Supreme Court made a decision back in 1999 that said, I don't know, it's, people have a right to live in the community and work in the community. So I guess if I'm being inconsistent with my current understanding of federal law, how long is it going to be before somebody starts, lining up the lawyers and saying, here's some lawsuits coming? I don't know. But here's what I don't believe you should do, Christina, is incentivize the insurance companies, because the insurance companies only care about their bottom line. And I can say that boldly because we've seen it over and over and over again. Unless you have a true insurance company. I mean, why is it that a CEO of an insurance company gets a 90% pay increase, and yet his workers that are CNAs and PCAs are dwindling for 15 cents an hour more, right? Yet 90% pay increase of somebody, and I won't name the insurance provider or the care provider, but let's just say they made the news the last couple of weeks. But their CEO, $3.5 million. I'm in the wrong business here, guys, right? That's just absolutely bizarre to me, right? And so Jim said this earlier, right? Priorities. Where are our priorities? If we're going to focus on our right priorities, then let's do it. So I think you incentivize the people, the organizations that are providing the services in order to bring people in there. So
great, thank you. Let me turn to Jamie Gulley. One of the findings of the report actually reinforces previous work of showing that unionized workers earn more than non-unionized workers. So when we're talking about a policy aimed at increasing wages, unionization is one of the other solutions that this report points to. Can you tell us a bit about how much, what percentage of this workforce in Minnesota is already unionized? You mentioned that this sector is a big constituent of your union.
Yeah.
And what are the challenges of unionizing? And you had mentioned before we started our conversation and before we started recording that you're now in some union negotiations. Tell us a little bit about what your union is fighting for right now for direct care workers.
Thanks so much. We about half of the home care workers in Minnesota are unionized with our union, and 32% of nursing home workers are unionized between us and a couple partner unions. And so, it is a large group of workers. And to Hannah's point on the question, as far as, we're seeing these backups in the hospitals, it's 100% true just how penny wise and pound foolish the payment systems seem right now, where we're spending 5 times as much if you're in the hospital as if you're discharged, 3 times as much if you're in a skilled nursing facility, nursing home, as if you're at home. And we know that almost every single person, if you ask them, would like to get that care at home when they're recovering or just trying to live their lives with as a senior or person with disabilities. And so the low wages effect here has a huge amount of cost to the system and to other individuals, including in the hospitals, and all of the frustrations that we experience in the other healthcare settings. The number one thing that we need to see is higher pay. And yes, union workers make a little bit more than non-union workers, as you might expect, but we also stay longer. There's a lot more retention. You see a lot more continuity of care. It is great for the residents of nursing homes, for the people who get the care in their homes, to have consistency in a caregiver. And I don't think you can put dollar values on how great that is, how many illnesses and issues are prevented by this workforce, direct care workers, nursing home workers. Just so much harm is prevented by having a robust set of caregivers. The demographics of our state is changing. The growth of seniors is growing so much, and then the women and especially the women of color in our state, that segment of the workforce is growing way less than the increase in seniors and people with disabilities. So we're seeing a squeeze, and if we don't raise pay, and what we are saying, we're in bargaining with the state of Minnesota for the home care workers here this week. What we're saying is it's time for $20 an hour for these individuals, and it's time for some meaningful benefits for these folks. We don't have a retirement plan. We don't have health care unless we get it through Minnesota Care or through a spouse or through another job. We really need to have some improvement here. And I would say, and we would offer as a union, that whether you work in a hospital, in a clinic, a nursing home, or home care, wherever you are providing care on that spectrum of care for our patients and for those in our community who need services, we really should have equal pay for equal work. You shouldn't get paid less because you work in a home setting or in a nursing home setting. And when we accomplish that, you're going to see a lot more efficiencies and a lot more savings to the state as we're paying the right amount of services for the care in the right place, rather than overpaying as people sit in hospitals trying to get discharged, but you can't find enough workers in a nursing home or a TCU or in home care for that individual to go to the right setting for their care. So it's time for 20 in our view. It's time for meaningful benefits for these workers. And I'm really pleased to see the results of this report. Well, we kind of knew it to be true in our heart, to see that bearing out in the data here in a more skilled and scientific way.
Thank you, Jamie. I think it's important for all of us to keep in mind that that it's not just pay, but it is things like retirement benefits. It is things like, so for example, paid family leave is also on the legislative agenda. That can also be extremely important for low-wage workers, as long as that legislation is designed to cover them. That's, we need to make sure that part-time workers, low-wage workers have access to this kind of basic infrastructure that allows us to step up and be a part of the workplace, and bring our whole selves as workers to the workplace to take care in these caregiving domains. I want to turn to, in the very few minutes that we have left, to Dr. Dill. In this report, you and your co-authors explicitly recommend not turning to training and credentialing programs. I think we're all on the same page as Senator Abeler when he stated that we want to see ways in which these workers can move up and have greater opportunities over time, but you don't see this as the pathway towards that. Can you explain a bit why?
Sure. And of course, I don't want to discourage career ladders. I think that they can be meaningful. And I always advocate for what I would call the nursing career ladder, which is giving people access, especially nursing assistants and home care workers, access to nursing education and allowing them to move up, because the difference between being a nursing assistant or home care worker and then being an RN or a BSN is life-changing. It's the difference between poverty level wages and, participating in the middle class. So I always advocate for the nursing career ladder. I think it's an incredible tool of racial justice. That said, for direct care workers themselves, I think in many female-dominated occupations, what we've seen is to increase credentialing in the hopes that employers will be willing to pay more for the credentials that workers earn. So an example of this would be for medical assistants. You don't have to have a medical assistant certification, but you can, in almost every state. I think the exception is the state of Washington, but you can opt in to getting your certification as a medical assistant, and then employers might be willing to pay you a little bit more for that. However, there's not a lot of evidence that these kind of credentials actually benefit workers. And many employers say that it's a barrier to keeping people into the field, or getting people into the field and keeping them there, especially for women of color who have less access to the educational system. So it can be somewhat exploitive. It requires workers to invest their own time and money, often into more training. And what often happens is workers end up getting many low-level certificates that don't actually help them to advance their careers. They get stuck in a cycle of more and more training and education that doesn't actually result in any upward mobility. The exception to that are, what I would say are sort of like meaningful career ladders, like the nursing career ladder or other mid-level mid-level healthcare credentials, but workers often have a hard time accessing those. So for direct care workers themselves, I'm always hesitant to recommend more credentialing.
That's absolutely good to hear. That it really is. You get a little plaque that says you just got this new credential, but what does that mean for me? It's absolutely spot on. How can you get that message to the Department of Human Services to those advocacy organizations that keep pushing for more credentialing? Hey, I got a great new organization out of whatever, Oregon, and they got this new credential. And if you get this new credential, you're a brand new whatever, you're credentialized, right? I love that statement, Dr. Dill. How do you get that to the place at the top? Jim, Jamie? Sorry to take over the moderation, Christina. That's just my ADHD kicking in, and that's all there is to it.
All right.
Of course, we want workers to have the skills they need to be successful, but I would say often workers already are successful, right? And then they're being asked to get this credential on top of what they already know.
I think in
Maybe,
some
do you wanna jump in?
respects, yeah, I was gonna say, I think in some respects I concur with the conclusion, but I don't want to diminish the importance of treating direct care work as a profession that people can advance in and not just advance from.
Yes.
And I think that credentials and opportunities for training and advancement are very important. And the one exception you said there, Washington State has one of the strongest, education programs and the strongest home care sectors in the country as far as caring for the population. And I think that they're a good example to look to for how do you create a trained professional workforce that can really care for folks. And so I do agree it can be a barrier at times and an illusion of progress towards meaningful pay and benefits, but to the degree that it can advance you within the direct care workforce, I think it's still something that should be available to workers to pursue.
Yeah.
So we have just 1 minute left. And so with that minute, can I ask Senators Abeler and Hoffman, what's on the legislative agenda as we look to the new session in the new year to address this issue? Very brief.
Let me defer to my incoming chair.
Thank you. Last year, Jim had the bill. It was well prepared, well done. People worked on it. Jamie, Rick Varco had worked on that. I mean, there was a whole group of people who worked on a great bill. And my hope is to bring that bill back to life and give it new abound life, because it really was a stabilizing factor. The other one is the Connect 700 program that we have in Minnesota. We had Bobby Silverstein had really helped our folks. Jim's office and my office, our staff, Kevin, had worked on for 2.5 years. And then some folks presented a bill that absolutely levelized that system, meaning it gave accessibility and equal opportunity for people with disabilities to work in state government. And my hope is to bring that bill back and get that through too. So I think Jim's bill that he had last year, it's a great base. I mean, it absolutely has everything we need to it. Let's build on that. Does that help, Jim? Is that anything else I'm missing?
Perfect.
All right. Well, with that, I really want to thank our guests for coming. Please do look for the report. You can find a digital version at z.umn.edu/essential and exiting, and that will be up after we close out this event today. You will also be able to find a recording of this webinar early next week on our Humphrey School of Public Affairs YouTube channel, and we will share the link with everyone who has registered, as well as in our email newsletter. You can go ahead and sign up on our website for the CWGPP email newsletter at any time. And so again, thank you to Jamie Gulley, Janette Dill, Senator Jim Abeler, and Senator John Hoffman. It's been a good conversation, and we hope to see some progress on this issue.
Thank you.
Yeah.